Firstly, thank you for the opportunity to be here, and thank you for the Effective Project and UEA's work. We're really proud and pleased to be associated with it from Alzheimer's Society. What I wanted to do was say a little bit about where we come into the picture and how we see things, a little bit about the context, something specific about our experience of hip fracture treatment and some case studies that come to us, and then a couple of thoughts about the way forward. And I hope that will give a few minutes that will give some sort of context for the discussion going forward. So picking up on what the Minister said, joined upness is absolutely critical, and we haven't really got it at the moment in the health system and the health and care system. One of the things I'm very pleased about, and one of the sort of elements of the Alzheimer's Society, is that we bring different elements together in the way we work. So actually, at the very core of what we do is research. My board of trustees have made a commitment to spend, which my fundraisers love, by the way, but they made a commitment to spend at least £100 million on research over the next 10 years. And by next year, we will have got to £10 million a year. So we're actually, and that will be a minimum of commitment. But the other interesting thing we've done, which I think is groundbreaking, not just in UK terms, but internationally, is that we've now split our research panel into two groups. We have a biomedical research panel, because there's lots of work we're doing in the biomedical field. We've got a really exciting drug discovery program, for example, where we're looking at repurposing existing drugs. And nobody else, the pharmaceutical industry has no financial incentive to do anything because they're off patent. We can take a drug like liraglutide that's used for diabetes. We're doing a research at Imperial on that at Hammersmith Hospital, where we're saying, can you repurpose this drug and use it to treat Alzheimer's? And of course, you can do it quickly because it's already been tested for safety and so on, and relatively cheaply. So there's exciting biomedical research we're doing. But the other thing we're doing now is a separate strand on healthcare and economics of health research. And that was actually, as in many charities, was becoming the poor relation often, because the biomedical guys would come up with lots of science and they would talk about the amount that needs to be spent, and it would all be peer reviewed by themselves, and then they'd award the money to themselves. What we've now done is, I'm being slightly flippant, but we've now set up two panels where we now have a separate panel looking at health and social care and economic research to make sure that we're putting enough resources into that. Because the truth is, and I know the World Dementia Council are aiming to get a disease-modifying intervention by 2025. To be honest, it's going to be luck to some extent whether they get there. You can't measure the pace at which biomedical research will go. Will there be a drug treatment by 2025? I don't know. But also, probably what will happen by 2025, if we even get there, and I hope we do, is that we may find a treatment that you start people on in their 40s or 50s, which may have an effect on whether they develop dementia in their 70s and 80s. So for the foreseeable future, for the next generation, for the baby boomer generation, as I point out to politicians, 3 times more likely to vote than anybody else, for the baby boomer generation, it is very important that we improve the care and support of people with dementia, because for the next 20 years, 30 years, probably that's going to be more important than any drug intervention. Beyond that, let's hope the drug and the cure will come through. The other thing is that in doing that work, in doing that research, we are bringing, through Alzheimer's Society, the voice of people with dementia and their carers forefront of the engagement. So working with Perfected and other researchers, we bring our research network into play. That's a group of about 250 people who have experience of dementia themselves, either with dementia or carers of people with dementia, and they work in a true partnership with the academic community. It's quite fascinating, because I've been a chief exec of a cancer charity before coming here, and we involved people with experience in the peer review process. More times than not, by the end of my time there, it wasn't just a tokenistic thing, it was actually a genuine partner. But then it stopped, and the research went ahead, and at the end of it, out at the other end of the sausage machine came the results. We've now got this partnership working with people affected by dementia all the way through. And I was in our conference earlier this year, and there was a researcher from Cardiff. And I said, what's the value to you? And she said, well, because I've got somebody with that experience, I took their advice and I short-circuited a blind alley that I was going up in my research, because I thought they probably know more about it than I do. Let me take their lead on the direction I take. And she said she probably saved 6 months of her research time by taking the advice of the experts, which she saw as the person with dementia and their carers. So that partnership that focus on research, that partnership with people affected by dementia is, I think, something that we're very proud to bring into this community, into the research world. But then the other things we do in terms of our local service delivery, 3,000 local services up and down the country, the development of dementia-friendly communities, as Norman has referred to, the work we do, pushing politicians to go that little bit further than they want to go, and also the information and advice services we provide are absolutely fundamental, and they hopefully all join up, and that's the aim. So that's a little bit about the context for us. The context for me in terms of us all here today, I think is really exciting because I think we have now changed the tide. We've now got a focus on dementia that wasn't there, and all credit to the Prime Minister for taking dementia as his challenge. We worked hard to get him there. He made the speech at our conference in 2012. I fully expected it to be tomorrow's chip wrapper, but actually he's stuck with it. And the ministers, Secretary of State, Norman, have stuck with it because they know that the £26 billion dementia costs the economy each year, the growing number of people, actually is unsustainable. And the quality of support is not what it should be. So we've got a momentum now. I was on the bus the other day going down to South London, and there were two women behind me on the bus talking about their friend who had Alzheimer's. And they were actually getting it all wrong, and I almost turned around and said, "Excuse me, can I just help?" And then I thought that would be a bit rude. But then I thought, actually, the important thing is they were having the conversation. And I don't think 5 years ago they would have done that. They would have said, Mary's got dementia or Alzheimer's, don't really know what that is, probably not very nice, not much we can do about it, let's talk about something else. But they were saying, they knew it was a disease, so that was stage one, that was pretty good. But they were talking about what can we do to help. And I think that is a seismic change. And it's how the health service and how the system responds to that is absolutely vital. And three things spring to my mind as actually playing into our hands, and the work you're talking about and this research is fundamental to that. One of it is the Reith Lectures, is Atul Gawan's Reith Lectures, and I was reading his book last week in the prep for that. And it is rethinking the relationship between the medical professional and the consumer, and what is our role. And as Norman said, we've extended life. But we've extended life, but we haven't necessarily extended quality life. So what is it we're doing that gives people not just more years, but more good years of life that they can appreciate, that their families can appreciate, that makes life worth living? So I think there's something there that's being put in the limelight through the Reith Lectures, and they in turn are reflective. The reason the BBC even wanted to have Atul giving the Reith Lecture shows that there is a public interest. Secondly, specifically on dementia, one thing the government's committed to is to come up with a new vision for dementia, looking beyond the next election, looking beyond the current national dementia strategy that runs out or has run out this year. What is it we want to achieve in the next 5 years? And a very strong commitment come from the Minister and his colleagues is that we need to set that out. We need to be very clear. I think we can make some very firm commitments. The Department of Health is saying you can't commit the next government. I actually think you should probably commit the next government. We don't put the building of Trident on hold until we have the election and then decide whether to restart it. So I think on dementia, we probably can make some pretty firm commitments that we will expect any future government to follow through on. And I think from my talks to politicians of all colours, although Nigel Farage hasn't replied to my letter, but of all the others, but I have written to him, is that everyone sees this as a non-party political issue. This is a societal issue that needs tackling. So those, I think, are the context of why this is a good place to be, why this is important. But come back to what I said about Alzheimer's Society and bring it back to why we're here today, and exactly what the Minister said. We don't have the research evidence that we need. We simply don't have the argument strong enough about what could we do differently to make the system work better, that gives better outcomes for patients and costs less, or certainly doesn't cost more than the current system. And that's the problem that we back up against, and I'm sure the Minister does when he goes over the road to the Treasury and they say, prove it. Because it's all too easy to say, let's invest more in community support and we will save money in hospital care. And they say, oh yeah, that's like, you promised that, you'll save money tomorrow, but you want us to spend today. And I think the work this project does is actually identifying, through some very detailed analysis, what is it that makes a difference? And if we could have more of these research studies doing that kind of detailed examination as to what will make a difference, it's fundamental. It will then drive, in my mind, some changes, not just in happens in primary care and secondary care, but also in the community support. It should change the kinds of things that our dementia advisors provide from the Alzheimer's Society. What is it we do to better support often frail elderly carers who themselves are vulnerable, who are caring for someone with dementia who has had a hip fracture. What do we do in the community? How do we push forward what is an increasingly open door from the more enlightened, I think, of some of the GP practices, which is saying we can move away from the 10-minute visit, because the 10-minute visit treats an episode of disease. And actually, the majority of support people now is support in long-term conditions. And I was talking to the chief exec of the Hurley Group, which is one of the biggest, probably most forward-thinking group of GP practices, who are saying we want to do much of the 10-minute visit online, electronically, automatically, or it can be done by pharmacists in the local pharmacy. Let's get to a point where the bulk of the people coming into the surgery have 30-minute or 1-hour visits, where we talk about the totality of their needs, and we talk about how, firstly, whether they have dementia, because if you haven't diagnosed the dementia, often that's the barrier, not just the dementia support, but it's a barrier to talking to them about their diabetes, their eyesight, anything else that's affecting their life, because the dementia might be the barrier to even a good engagement and conversation. But then let's also talk about how do we prevent them having the hip fractures in the first place, as well as how do we better support them when they do have the fractures. So I think there's an engagement process that this research will fuel. I think there's something about looking at the hospital experience, and this is where I wanted to give you let me just read you 3 case studies, because this is what we get back from the work we do. I just thought I'd share these with you and just give you a flavour of what people have told us. And this is from surveys we've done and what's come back through our research network and others. So I'll just read them out. They stand on their own. Exactly a year ago, Mum fell and broke her hip. The process she went through, including hip replacement under general anaesthetic, was this really the best option for her? The 3 weeks in hospital left her a confused and frightened person. Me having to go in to give her lunch every day to make sure she actually had lunch, as the young lads serving it would often assume she didn't want anything because they didn't understand her needs and didn't have time to feed her. Trying to get her up and walking again and being told actually there wasn't any point trying, and the ensuing weeks that led to her death 8 or 9 weeks later are all still very fresh in my mind. So that's one person who spoke to us recently. Second example. At the age of over 93, my father, who had vascular dementia, fractured his hip, and communication with those in charge at the hospital was abysmal. To cut a long story short, subsequent to my father's discharge from the hospital, I was in contact with the head of its PALS division, who arranged a meeting with everyone who had been responsible for my father's care, from the surgeon to the physio, from the housekeeper to the head of catering. Following on from that, the hospital instituted a training programme for all hospital personnel based on video interviews of patient families who voiced their concerns, both negative and positive, about the treatment their loved ones had received. The videos were also shared with the hospital trustees. So actually that's a lovely story, which to me, which we find all the time with the people who engage with us, is actually people who've been through a traumatic experience, but then actually want to do something to support other people to avoid them having that traumatic experience. So it's turning the negative into a positive. And as one example of that cross-hospital engagement is the work Guys and Tommies have done with Barbara's story, which some of you may have heard of, which is a soap opera, really, that they've told of what it's like for somebody with dementia in hospital and the different things that happen to her, right through from an AE admission, planned admissions, end of life, every different type of hospital engagement. They've shown that video to every single person in that hospital, from the chief executive to the cleaning people and the orderlies. Every single person, 16,500 people, have seen that, and it is changing the way the hospital behaves. What's lovely is they're changing it bottom up. So the porters realised, having watched the film, that actually it was very disorientating to do what they did, which was to pull people through the hospital backwards without them seeing who was pulling them, without them seeing where they were going. So they unilaterally decided to change that. Didn't need a management instruction, they just decided to do it differently. The people serving the meals, as in that first case study I gave you, are now thinking, does this person actually want to eat but doesn't realise they want to eat? What can we do to help them? Can we work with people like Alzheimer's Society, RVS, to bring somebody in who can actually support them and make sure they don't end up malnourished and going out of hospital less well than when they came in? And then the third example I give you is my mum broke her hip and then had to have a hip replacement. I stayed by her bedside from 8 in the morning until gone midnight some days while she was in hospital before and after the op. I then brought her home and looked after her. She did manage to walk again. My aunt some years ago also broke her hip which resulted in her admission to a care home. She had vascular dementia and never walked again. So again, somebody who could relate to their own experience and see progress, could see what could be different. And I wanted to end just by talking about one aspect of it, which is the Right Care programme that we've put in place through the Dementia Action Alliance for hospitals up and down the country. And Minister did a fantastic job about a year ago and wrote to every hospital chief exec and said, you should be part of this programme. I think 146, I think it is, 143 or 146 hospitals have responded. So almost all major hospitals, almost all hospitals actually have said they're going to be part of this programme. And it's about then putting in place a customised development programme that we support, the NHS services, different bits, Health Education England, everyone plays their part in supporting a change programme in that hospital to actually make the difference. And the one example I was going to give you, I just randomly looked on the stories that are on the website from the Right Care programme. And the one I picked out, because it was very simple, showed that none of it is actually rocket science, was the George Eliot Hospital in Warwickshire. And they have 5 points to their action plan that they've agreed. One is improving staff awareness and education to ensure that staff are sufficiently knowledgeable about the complex needs of patients with dementia. Secondly, to engage with partnership organisations, patients and carers to improve our existing care pathway for the management and care of people with dementia. Thirdly, improve the quality of patient care and patient experience by engaging with patients and carers and listening to their views. Fourthly, improve patient safety in relation to specific high-risk harms, falls, malnutrition, hospital-acquired infections, UTI, etc. Finally, to adopt the National Commission for Quality and Innovation measures for dementia, sequin measures for dementia, and ensure that patients with memory problems are assessed, investigated, and referred for specialist assessment and diagnosis. That's what they're putting in place, and it finally brings me back to something you may have seen, but I'd commend to you. When the National Dementia Strategy was produced in 2009, we did a lot of work and a survey, very extensive survey across people with dementia and their carers, and we came up with what's called the National Dementia Declaration, which is at the core of the Dementia Action Alliance, and it's a set of I statements. They're all, I expect this, I have a right to this. They are very basic. They are 7 I statements. And the remarkable thing, and that's why George Eliot is an example, because none of those are that difficult to do. Remarkable thing about the I statements is that they are all things that all of us would normally expect in everyday life. They're things that they're not exceptional. They're saying, I want to be treated like a person, I want to be listened to, I want to be responded to, I want to be supported. And I think what you're doing in this research program will provide enormous evidence, which, as I say, will fuel some of those debates going on now and will help us win the argument for the resources to be spent in the right way, to the right effect, to make the greatest difference. Thank you.